Anand is not coming. Anand Pascal.
Join, ma'am.
We are live now, doctor.
Yeah, thank you. So let's start. So very good evening to all of you. So on behalf of Tamil Nadu Ophthalmic Association, I extend a heartfelt welcome to our distinguished guests, speakers, participants, and all the viewers today for the TNOA Eye Donation Fortnight webinar. So I'm deeply honored to stand before you and welcome you. So this webinar holds a special place in our heart as we shine a spotlight on the remarkable advancement in corneal surgeries, particularly the game-changing lamellar surgeries. So these innovations have revolutionized the eye donation movement and significantly elevated the standard of care and patient outcomes. I want to take a moment to congratulate the dedicated team behind this, particularly Dr. Sharmila, Dr. Seema, Dr. Samudaram, who will be moderating the session and part of panel. And our esteemed speakers today, Dr. S.K. Rao, Dr. Sujata Mohan, and our Vice President, and Dr. Anand for generously agreeing to share their time, knowledge, and expertise with us. All three are really great speakers with so much experience with them in the lamellar surgeries as well as the entire corneal work. So thank you, speakers, for accepting our invitation and sharing your time with us. So to our participants and viewers, your presence here signifies your dedication to the eye donation movement, particularly during this fortnight. So we've been hearing and seeing a lot of eye donation activities in our state as well as across our country. It's a wonderful public health initiative as well as takes TNOA to the public domain also. We're also hearing a lot of media messages in all social media, electronic media and print media. It's nice to be part of this social initiative. So this webinar is a platform where knowledge meets curiosity, where ideas spark innovation, and where we come together with a shared vision for a public health cause. And so once again, a warm welcome from TNOA to all of you. So I encourage all of you to actively engage in the discussions. If there are any questions, kindly put in the chat box so that our moderators can take up with the esteemed speakers. So once again, welcome all of you for this TNOA webinar. And I request our Vice President to say a few words, and it's over to you, Sharmila, and also Secretary Dr. Sriram.
Hello, everybody. It's indeed a great pleasure to be part of this Eye Donation Fortnight celebration by Tamil Nadu Ophthalmic Association. Dr. Nirmal has gone at lengths to make it as interactive as possible. And thanks to Sharmila for organizing such a wonderful meeting. And over the past 1 month, we have seen a lot of activity in TNOA. So I think that itself shows how important it is to carry on the same work that Nirmal is doing. All the very best, Dr. Nirmal. You've done a wonderful job the past 1 month, and I'm sure you're going to carry on the flag of Tamil Nadu Ophthalmic Association further. And I'm extremely thankful to Dr. SKR and Dr. Anand for participating in this conference. So lamellar keratoplasty, I think my first introduction was in 2004 when there was a conference in Shankar Nethralaya. When I saw the lamellar keratoplasty being done, I thought I'm not going to do it ever at all. But in 2006, I started my first DSEC. And from then on, there's been no looking back. And now it has become the gold standard. It's not like, it's like going back to ECC. It's like a phaco now. So I think all corneal surgeons have at one point of time have to do lamellar surgery. And a good initiative by Dr. Sharmila to have this webinar during the Eye Donation Fortnight. All the very best to everybody.
Dr. Sriram.
Thank you, Madam. Dr. Sriram, Secretary of TNOA.
Good evening, everybody. Thank you, sir. Thank you so much. For people who are retinal surgeons like me, actually, I hope this webinar will actually serve as an eye-opener because a lot of times I cannot tell the expansion of DMEC and DSEC itself. So a very, very welcome thing for a lot of people who are even not corneal surgeons. I'm really eagerly looking forward to listening to all the doyens, especially SKR sir. Thank you. Thank you so much. Let's move on.
So thank you, Sriram. And it's over to you, Dr. Sharmila. Sharmila needs no introduction to TNOA's audience. She's the corneal surgeon and senior assistant professor at Arriva GOH, and currently the joint secretary of the Tamil Nadu Ophthalmic Association. So over to you, Sharmila, to take care of the webinar.
Good evening, everyone. It's my pleasure to welcome you all to the 38th National Eye Donation Fortnight webinar. Eye banking is not just about the numbers anymore. It's about the quality of tissues and about good, successful surgical outcomes. And lamellar keratoplasty has revolutionized the corneal transplantation techniques. And, there are very good, successful long-term results with lamellar keratoplasty. But there is also a learning curve with lamellar keratoplasty. And the goal of this webinar is to shorten the learning curve for the participants who are viewing this webinar today and for the participants who will be viewing it in future on YouTube. So we have with us three eminent speakers and prolific surgeons, Dr. Srinivas K. Rao sir, Dr. Sujata Mohan ma'am, and Dr. Anand Parthasarathi. We'll be sharing tips and tricks for not only the novice as well as for the experts. And we have a stellar panel of corneal specialists here. Revati ma'am has a lot of experience in lamellar surgeries, and she's the chief cornea services in Aravind Eye Hospital, Coimbatore. We have the senior cornea consultant from Aravind Eye Hospital, Chennai, Dr. Seema Ramakrishnan. And we have with us Dr. Soundaram, cornea specialist from Clarity Eye Hospital, Chennai. So I'll just move on to the introduction of this first speaker. Can you just slide share it? Can you go to the next slide? Yeah. So Srinivas K. Rao sir is fondly called as SKR sir, and he did his he's an alumnus from Madras Medical College, and he got his FRCS from Edinburgh. So he did his specialized training in it's not very visible because it's not slideshare. He underwent training in corneal disease and surgery at LA, Dallas, Boston, and New York, and he trained for phacoemulsification in Calgary, Canada, and LASIK in Minneapolis. He's underwent lamellar corneal surgical training in Rotterdam and keratoprosthesis surgery in Italy. He's certified for advanced IOL surgeries and alpha core prosthesis. He was a senior consultant in Shankar Netralia between 1991 until 2004. And resigned as a senior consultant cornea service and director international relations in 2004. He was professor at the Department of Ophthalmology and Visual Sciences, Chinese University of Hong Kong, the largest university in Asia, and he was there till October 2006. He returned to India in October 2006 and founded Darshan Eye Clinic and Surgical Center, where he is the director till date. Currently, his clinical positions are he's the director of Darshan Eye Care and Surgical Center, Chennai. He's the director of cornea service in Sunetra Family Eye Care Center, Kolkata. He's a consultant at Madras Medical Mission, Chennai. He's a chairperson in Rajan Eye Care Institutional Ethics Committee, and he's also an honorary associate professor at the Department of Ophthalmology and Visual Sciences, the Chinese University of Hong Kong. He's also a section editor and reviewer for many international journals. He's done some pioneering contributions, and most notable among them is he performed the first osteo-odontokeratoprosthesis, and he has also performed autografts and allografts and posterior corneal transplants for the first time in India. Over to you, sir. He'll be talking on deep anterior lamellar keratoplasty.
Can I share my slides?
Yes, sir.
Can you see my slides and hear me, please?
Yes, sir.
Okay. So thank you very much. Good evening, everyone. Thank you, Sharmila, for the introduction, and Dr. Nirmal for the kind invitation, and Dr. Sujata as well. So looking forward to the session and the learning. My job is to talk about anterior lamellar keratoplasty. The other two speakers are going to speak about the posterior versions of this surgery. Anterior lamellar keratoplasty actually started almost at the same time as penetrating keratoplasty. But unfortunately, because of the poor outcomes that were seen in the early days with this surgery, it lost out. And for nearly a century, PK or penetrating keratoplasty was the favored procedure. This changed when we understood that we needed to do deep anterior lamellar keratoplasty to have good outcomes. And in the last almost decade and a half or two, this has become the standard of care for diseases of the cornea, which have a healthy endothelium, because we do not want to sacrifice the host endothelium.
Excuse me, Dr. Rao, we are not able to see the slides as such.
So I thought you were giving an introduction, but none of the slides have come up.
I'm having this problem with Keynote on Zoom. We had it at one other meeting, but I thought it sorted out.
Yeah, it has come now.
Yeah, it's come.
When I share, I think you have a problem, is it? Or there's a big delay, I think.
Came previously.
Just give me a minute. I'm trying to sort this out. I'm going to play it again. There should be a slide with some corneas on it.
No, now it's black screen.
See,
I
actually,
think
the first slide you showed had 4 corneas.
Yeah, it's come now. I think there's a time gap. I think it comes after some time. I think we just
lag is there. Keynote might have some lag. So, or you can present with the screen on.
Can you see it now or
No.
Not really.
Yeah.
really?
Now it's coming.
I think when I take away the screen, it comes back. I don't know what.
Slide share, so
I'm sorry.
you can just present it like that without the slide share.
Okay, I'll do that, but the videos I hope will run. Anyway, let's see. So basically, my job was to talk about the various aspects of anterior lamellar keratoplasty, try and give you an understanding of, like Sriram said, what the various terms or the acronyms we use stand for. And we also talk about type 1, type 2, type 3, and so on in terms of the bubbles that we use. So I'll try and see if I can simplify that for those who have not done this procedure before. Now, this slide basically shows 2 images on the top and 2 on the bottom. These are 2 fellow eyes of a patient. One eye had a penetrating keratoplasty and the other eye had a deep anterior lamellar keratoplasty. This is, if you can see my pointer, the top left is the PK eye and the bottom left is the DALK eye or the deep anterior lamellar keratoplasty eye. I can tell because I did the surgery, but the other ways of looking at it is to look at the size of the graft. PKs for keratoconus generally tend to be a little larger than DALKs. And the other way, of course, is to look at the slit beam and look at the graft-host junction. In a DALK, it's often a lot more regular because you have a posterior bed as opposed to a PK, where sometimes you may get a little irregularity there. And the last thing is to look at the interface, but if it's a reasonably well-done DALK, there will be no interface at all. Sometimes if you leave some talc particles here or there, then in the postoperative period, you can use that to identify the interface. But otherwise, it looks almost as pristine as a penetrating keratoplasty. So basically, if you look at the surgical nomenclature, the early attempts at lamellar keratoplasty worked somewhere in the anterior 2/3 of the cornea. And this resulted in the poor outcomes because this part of the cornea is reasonably well populated with keratocytes. And when you put in tissue here and try and suture, there were 2 problems. One is the keratocytes tended to cause a lot of scarring in the interface. And second, matching the donor thickness to the bed that you had created was problematic. It required very skilled surgery to match that 60% depth that you created in the host and do the donor at the same depth, which was all the problems. Once we realized that we had to go deeper, and once we started doing what is called the D-DALK or the decimatic DALK, where you split almost all of the stroma away from the decimes, then there is virtually no keratocyte left. And that is why in the previous picture, it was almost impossible to see the interface. And second, because if you're going at that depth, all you have to do is to peel the decimes membrane off the donor and you get perfectly matched tissues. So that aspect got solved as well. But getting to the decimetric level may not be easy in all patients, particularly in very advanced keratoconus and in some other diseases. And therefore, we've learned that if you can do a pre-decimetric DALC, which means that you're somewhere at the 85 to 90% depth in the cornea of the host, you can still get excellent outcomes, because in the last 10% of the stroma, the keratocyte density is very minimal. And this 10% does get adjusted even if you're removing only the decimates from the donor and putting it in. This whole surgery really took off when Dr. Mohammed Anwar from Saudi Arabia described this technique of injecting an air bubble to separate the stroma from the posterior cornea. And this is really what made deep anterior lamellar keratoplasty as popular as it is today. When you look at this picture, these are the air bubbles. This is the stroma of the cornea, and this is the air bubble here, the big one. These are the frog's eggs. And this is cleaving this layer off from the cornea. And for a very long time, we thought that this was the decimetric DALC. We were right down to the decimates. The air bubble had split all of the stroma away. But as with everything, things keep changing. And Professor Dua from Nottingham showed us that contrary to the classical corneal teaching, when I studied cornea, when I started ophthalmology, these were the layers of the cornea: the epithelium, the Bowman's, the stroma, the decimates, and the endothelium. And he actually showed that there is this black layer here, which he added on, which is a sixth layer now. And he called it the Dua's layer eponymously. The Americans objected. So non-controversially, it is now termed the pre-decimetric layer, although in truth, I think you should call it the Dua's layer because he discovered it. So this Dua's layer is what really makes the difference when we do the different types of bubbles. And this video, if it plays, yeah. So if the bubble starts from the center of the cornea, if it is circumscribed and dome-shaped, if it has a white border at the edge, and if it extends to about 8.5 millimeters on the cornea, this we call a type 1 bubble. You can also get what is called a type 2 bubble. And if you can watch this area of the screen here, the upper right part of the cornea, you'll see the bubble starts in the periphery here. It can be multiple and coalesce. It can extend much larger than the 8.5. As you can see here, it's going right out to the limbus here. And this has a very glassy appearance. So this is what we call the type 2 bubble. Now, the difference between these is because of this Dua's layer. When you inject air into the cornea, if the air enters the space between the stroma and the pre-decimetric or Dua's layer, then you get the type 1 bubble, which is limited to 8 or 8.5 millimeters on the cornea, because the Dua's layer gets firmly attached to the cornea at that point, and the bubble can only cleave it off up to here. This is the reason why it cannot extend beyond. When you inject the air bubble, if it goes beyond the Dua's layer in the periphery and actually strips the red line, which is the decimates layer off, then the bubble splits the Dua's layer as well from the decimates layer. And this is called the type 2 bubble. And this is the reason why it can go up to 10.5 millimeters or right out to the limbus, because that is the attachment of the DM at the Schwal base line. There is no 8.5 millimeter limitation like you see with the Dua's layer. The type 3 bubble is when you get a combination of a type 1 and a type 2 in the same eye. Now, this is a surgery done in 2007. Basically, a 30-gauge needle is injecting air, and you can see this nice circumscribed type 1 bubble. So the technique basically is to open the bubble roof, get into the plane. You can inject a little viscoelastic if you like to separate the posterior layer and to keep it moist when you're cutting. And then just quadrant the anterior stroma above that cleaved off plane. And in the type 1 bubble, we now know that it's the Dua's layer or the 6th layer. This is a very firm layer. So no matter you do your manipulations, as long as you're not being very violent, it will work. You just strip the DM off the donor, put it in, and this is the surgery itself. Now, for the type 2 bubble, this is another surgery done again in 2007 when we didn't have these concepts, at least I didn't have them. So here again, basically, I'm injecting the air bubble, and the air bubble forms the type 2 bubble, which I have not realized. I can see the glassy bubble here, but I don't know what it means. So I go about with the classical technique of injecting something into the interface, separating it. And when I'm removing this quadrant, if you just watch what happens, because this is the decimates layer underneath, showing it to you again on this video. I'm cutting this here, and somewhere here, because of the gentle pressure that I've given, the DM broke. But this patient also had a cataract, so it didn't matter. So we took out the cataract, put in a lens, and did a triple procedure, and it worked out fine in the end. But the point here is that the Duas layer is much stronger than the decimase layer. And all the manipulations you do on the anterior stroma when you're cutting it will work out fine if you have the Duas layer underneath. But if you have the decimase layer, you have to be very careful. Now, this is a much more recent surgery done, I think, last year, October or so. So this is to show you the type 3 bubble. Another point that I wanted to make here is this is a 9 millimeter trephination because this patient had a very large cone and we couldn't encompass it with 8.5. And if you look at the right side of the host bed, you can see the host margin going all the way down to the posterior layer. If you watch the left-hand side of the video, you see a thin film of stroma here. This is because the Duas layer has stopped here at 8.5. This is a 9 millimeter bed. So you cannot really cleave this stroma off the underlying tissue. If you keep trying to do so, you will basically go down to the decimase. So when you recognize this, it's wiser to leave a thin strip or thin layer, 10% layer, if you will, of stroma there so that you can work. Now, if you look here, you can see another bubble here. These small bubbles are in the anterior chamber. This is the type 2 bubble. So this is splitting the decimase and the dua. So the way to deal with it is to make a little nick on the top, let the air out so that the underlying decimase layer can now reattach to the Duas layer, and then you can proceed with your surgery. If you try to open that bubble on the top, inject visco and try and remove even that thin layer, which is actually the Duas layer, then you'll be left with the DM underneath, and 9 times out of 10, you will end up breaking it. An occasional very skilled surgeon may get away with it, but I would not recommend it. I can't do it. In my hands, it doesn't work. Now, this is a video behind, which is not showing up here because of the confusion with this. Doesn't matter. So basically, this was the point we were making about not getting a bubble every time. So if you can't get a bubble, nothing is lost. You don't have to give up and convert to a penetrating keratoplasty. If you're willing to patiently keep dissecting layers of the cornea, you can use a knife, you can use a vanas, which I like. So you keep grooving and keep working. And when you make the initial injection of air, even though it does not split the layers, it will form frog's eggs in the corneal stroma. So as long as you see a thin layer of air underneath your scissors, you know that there is stroma underneath. And so you can bravely keep working. And like I said, you don't have to reach the Duas layer. If you're at 90% or 85% depth, like in this patient, we did a manual, ended up with good outcomes, and you get a clear interface as well. So in the other advantage of DALC is if you have somebody with an advanced pellucid like this, it's very difficult to do a penetrating graft because you know that the thinning is right out in the periphery. You won't get enough tissue to anchor it. And if you do a large PK out up to here, you will have rejection, you will compromise the angle and so on. So here again, DALC will help you. You can remove all the layers right out to the limbus as we've done here and sew it, and you can get reasonably good outcomes. This is a 10.5 donor on a 10 millimeter bed, and this works quite fine as well. So as far as this section of the talk was concerned, the take-home points are if you get a type 1 bubble, the pre-decimatic layer offers a nice safety net. You can bravely excise the stroma. If you get the types 2 and 3, be careful, and you need to have some principles. Our understanding of corneal structure is evolving, and to do this well, you do need appropriate instruments. What I mean by that is we come to the complications of these and the outcomes optimization. So in a PK, you can trephine right through, which means you can get vertical walls for essentially at least 3/4 of the circumference. In a DALC, you do not want to go through, so you have to trephine up to maybe 70% and then stop. So doing it manually sometimes is a challenge. And even if you do it manually, you have a posterior ledge that you must excise. So these are the reasons why there can be a disparity in the graft toast bed. The ideal way to do it would be to use some kind of a vacuum trephine because you can guard the trephine tells you how deep you're going in the cornea. And to some extent, you have control over ending up at 70% or 75%, which is where you want to stop. With a manual trephination, sometimes you go too deep, sometimes you just scratch the surface. It makes it a lot harder. And if you repeatedly keep trephining, you get irregular cuts on your walls. The other thing is about sizing. Most keratoconic patients for whom we do DALC largely have steep corneas, and you'd like to flatten it a bit with your suturing, the posterior layer. So the sizing of the donor becomes critical, which is not so in a PK. In a PK, if you take an 8 millimeter bed, an 8.5 graft is standard. In a keratoconus, in order to keep it the curvature a little better, we'd like to use an 8.25 donor. But if you're using an 8.25 donor, remember to trephine from the epithelium side. Don't punch from the back. If you punch from the back, the 8.25 will end up as 8.1 or so because it gets smaller when you punch from the concave surface. And if you have a bed and you put a very small graft in it, then you'll have to tighten sutures everywhere. And while you may get a clear graft, the astigmatism may not be very good. So if you do get astigmatism, as in this patient with a continuous suture, we tried to rotate these sutures to adjust the astigmatism. The suture broke. We had to snip another one in and finish it. But it doesn't matter here. Unlike a PK, where if the suture breaks at 1 month, you have a problem. Here you have a posterior layer protecting the anterior chamber, and you have time to adjust the suture. If you have a keratoconus or some other patient like a herpetic scar, you can still do a manual. This is a herpetic scar. I didn't want to do a penetrating keratoplasty. So I've done a deep anterior procedure after discussing with him with the manual dissection. So he ended up with a little opacity where there was the herpetic scar, but the visual axis was clear. He has 612 in the single eye and he's quite happy with it. If you don't remove your sutures on time, you can get vessels sneaking in. And because you have an interface in a dark, these vessels can grow in the interface very easily. They can take over the interface in hardly 2 to 3 weeks. And as you can see here, there is lipid that is starting to form there as well. So suture removal at the appropriate time is important because otherwise you get these vessels and this is what will happen. Sometimes, particularly in patients with macular corneal dystrophy, where you can have a little endothelial dysfunction, when you do a DALK, you may not get an apposition on day 1. You can see this kind of a cleft that forms between the posterior layer and your donor. But usually an air bubble will resolve it. This is the same patient after the second day air injection, and it will get better. The air can come with problems. You can get pupillary blocks. So if you do a full air fill, make sure you see the patient an hour later in the OPD, release some air if required before you send them away. Otherwise, at 9 o'clock, you'll get a call at home. Patient's got severe pain, he's vomiting all over the place, and then you'll have to head back to clinic at 10 and 11 in the night to solve this problem. Again, because you're using air, just like in a PK, you can get the Uretz-Zavalia syndrome in a DALK as well. You see this widely dilated pupil because of the sphincter atrophy. If you don't remove the sutures, apart from vascularization, you can get infections. And in most infections following suture getting loose, it is quite often a pneumococcus. And the important thing about knowing this fact is that pneumococcus does not respond to your 4th generation fluoroquinolones, which is usually a go-to medicine in infections. So putting an Agati or a Moxie will not work too well. You do need to use fortified cefazolin because that is the agent that works best against the pneumococcus. We talked about the endothelium being retained and that being one of the big advantages of DALK, unlike a PK where you get an endothelial rejection in a lot of patients, but you can get other rejections in a DALK. So this is a patient who's 1 year out of surgery. You can see some sutures have been removed. He comes in with a sudden onset haziness and bit of a glare. And you can see this haze in the cornea. You can see the corneal stromal swelling. This is a deep anterior lamellar procedure. So this is a stromal rejection. And it's not all that uncommon. We don't see it so much in a PK because there the endothelial rejection takes precedence. But here, stromal rejections do happen. So you keep looking out for them. Luckily, with just increase in topical steroids, it gets better in about a couple of weeks. You can also get other types of rejection. So this is a deep lamellar procedure, which we did for a fungus long ago. So because it was a fungal infection, even though he was doing well, I withheld the steroids until he came back on the 20th post-op day with this appearance. So when you stain it, you won't see a stain in the center. So this is not an epithelial defect. This is just a raised epithelial line. So this is an epithelial rejection, which is the other kind you can get in a DALK. We started steroids because it was 20-day post-ops and there was no infection. And 2 days later, it shrunk, and a week later, it went away. You can also get these kind of Kratchmer spots. You need to be able to distinguish them from the adeno subepithelial infiltrates, which can look casually like this. Sometimes the SCIs will occur on both the donor and the host, whereas the Kratchmer spots will only occur in the donor. They tend to be a little bit more diffuse and spread out, unlike the adeno SCI, which are usually more discrete. But it really doesn't matter if you can't make out which is which. Both need steroids to treat. You can use steroids and they will get better. So basically, like I said, if you follow some basic rules, if you understand the bubbles, the concepts, and if your suturing and your graft refination is good, you can get excellent outcomes with the DALK. It is a definite advance in corneal surgery. As we have seen, there are many ways to achieve outcomes. You can do manual dissections, you can do air bubble, you can do visco. I've not gone into the other ways of separating it because I wanted to keep it simple. But apart from air, you can also use visco dissections, which the Japanese group does. But air is generally the preferred method and done in most places. But even with a DALK, you can get complications. The one you can't get is endothelial rejection, but you can get other complications. But if you have proper intra and post-operative care, you can manage most of them in most of these patients. Thank you very much. And I'm sorry about the glitch with the slides.
Thank you very much, sir, for that excellent presentation and videos. It did play well, and it was pretty clear, just that it was not in the slideshare format. Sir, I just have one question for you. When do you decide to convert to PK when you have a perforation? Do you just navigate with a stroma? And
so basically, I'm quite conservative. There are many surgeons like Dr. Busen from Italy who will almost never, it's for him, it's almost like it's a failure. So he will never convert. He will keep fighting. But for me, my simple rule of thumb is if I have a perforation somewhere, I will inject a little air in the chamber. If the air stays reasonably well inside, then I will proceed. But if the air just bubbles out, even as I'm injecting, you can still manage it. You can put in a little stroma there, you can put in a fibrin glue, complete your dissection, this and that. But for me, if I have that, then I would rather do a proper PK and finish rather than have the risk of a second chamber the next day and then go back or some haze and stroma there. But this is a rule of thumb. This is what I do. But for me, if the air escapes freely through the perf, I will convert. But that is not necessarily the dogma. You can proceed even in those cases. And I've seen other surgeons do it. It's just my philosophy.
thank you so much, sir. And do you have any cutoff when it comes to severe advanced keratoconus, like 250 microns or something, where you decide to do a manual dissection instead of injecting a bubble?
No, unless there has been a previous hydrops and there's been a scar, then I will only do a manual, because if you inject air, there's a high risk of that scar giving way. So there it's manual. But the thickness of the stroma doesn't really bother me. It's just that in a lot of my patients who I do DALC for in other conditions, I will remove 50% of the stroma after trephination before injecting the air bubble. Whereas if I know it's only 250 microns and I won't bother removing anything, I will straight away inject using that stroma as the bulwark against which the air can force the DM away. But in a very advanced cone, the chance of you getting a good air bubble is slightly lesser. So you must be mentally prepared to go into a manual mode. But the air bubble injection helps because it insufflates the stroma. So when you're doing a manual dissection, the presence of the air underneath your scissor helps you proceed more bravely, really.
Thank you very much, sir. We have a stellar panel here. Revati ma'am, can you add some tips?
Yeah. Thank you, Dr. Rao, for the, excellent pictures you've shown, especially about the epithelial rejection and all. So otherwise, I don't think commonly we see this, very rarely we see, and it's really an, for others who have not seen it, it will be very helpful. And as usual, like very simple and clear talk. And the videos also, they played almost well only, like we could see very easily. And only one point I just want to add, like a case of if you don't get a big bubble, and especially very thin corneas, when you are trying to inject and you get only small bubbles, you can also try, along with the bubbles, you can also try hydro injection. Hydro dissection also you can try, because when I do hydro dissection, the going deep and manipulating manually will be easier because the tissue will be wet. So a chance for, and also bulge. So the chance for accidental perforation will be less. That is another thing you can add to it, add to your techniques. Otherwise, like you covered everything very nicely.
How about using visco, ma'am?
No, visco, personally, I prefer when I get a big bubble and after nicking it, I'll replace it with visco. But injecting visco in the stroma, a compact stroma, I don't think it's so easy. But when you inject the fluid, irrigating fluid, easily it will spread and the tissue will become very wet. So as you go deeper and manipulate, it will be like, it's very, I have done it many times, even in post hydrops scar also. So accidentally cutting, creating a perforation, the chance will be very, very less. So only in those cases I use that, not always.
Can I ask a question? Sharmila, can I ask a question?
Please.
I have a question for Dr. SKR. The problem when we come across very thin corneas and keratoconus is that you get a 500 micron donor and you have a 200 micron host. So is there any tip to overcome this? There's always a graft-host mismatch, how much ever you do it. Do you have any tips to overcome that?
In a regular keratoconic cornea, often that is not a problem, because I think the idea is to get the host refination way beyond the thin area. So I will often do a shame plug in these people, which you do anyway, but you can use the pachymetric map to kind of decide. So you don't necessarily have to just encompass the Fleringa, the Fleischer ring. You can go a little beyond. If you think the pachymetry there is a little thinner, you can go beyond to essentially normal cornea. So that should not really be a problem unless we're dealing with a very scarred cornea. Or in a PMD. In a PMD, no matter what you do, the periphery is only going to be 200, 300. So there, you still have that 1 millimeter of tissue inferiorly, which is normal. So there we do a peritomy if required and go right out to the limbus. So that is where the DALC really comes into its own, honestly, because if you do a limbus-based PK in a PMD, you know that is never going to work. The rejection is going to happen very simply. The PAS there will kill the pressure. So there the DALC will really come into its own.
And no, it also in keratoglobus, where there's extreme thinning, sometimes it can be a little dicey because it's almost like up to the limbus, and you cannot go up to the limbus to do the graft because you have to be careful with stem cells.
There, even though we are calling it a DALC, the technique is a little different. So what I personally do is we do a limbus sparing peritomy. So you very carefully open and then keep dissecting the limbus onto the cornea before you cut it. So you try and preserve the limbus cells. So this is a 360-degree opening. Then we use alcohol sponges to remove the epithelium of the keratoglobus. So you soak it for some time, a minute or so. Then you use another dry sponge and remove the epithelium. So there's no stromal dissection done at all. Then we take a corneoscleral rim, really. So it's got about a 1.5 millimeter of sclera. It's got basically the entire cornea. You remove the DM from that entire cornea, you put it on. So it's like a, on-lake kind of a graft. And then you suture. And because it's only the 200 micron or 150 micron in the back after you remove the epithelium, it really doesn't add too much to it. And this will work well. And then later on, if there's a lot of scarring, you can always come back and do a PK if you like later on. But to attempt the standard DALC techniques in a keratoglobus, in my hands, doesn't work. So this is what I will do in a keratoglobus.
Yeah, it's like epikeratoplasty or something like that.
Or
The
is
same
it
technique.
similar to tuck-in lamellar keratoplasty? Is it?
Actually, no, because there is no tissue here to tuck in. So that is for where you have, that's the Rasik and, the Ames group talk about it a lot. But I think if you're doing it with a femto, maybe you have some, but manually, I think it's a very crude method. If you can cut in those things with a femto and slide something in, you can, but not in a keratoglobus. There, if touching the stroma is asking for trouble.
Yeah, keratoglobus I have not tried, but in very large keratoconus or even PMD, I have tried that. The tuck-in in the periphery only. Of course, it's a very tricky, not that always you get good results. You can try that. But I don't think in keratoglobus, where limbus to limbus thinning, as Dr. Rao pointed out, I don't think it's possible.
I have one question,
Sharmila. Sorry, Dr. Shandaram, carry on.
Yeah, I have one question for Dr. Rao, sir. While doing the dissection, what about, how do you maintain the AC? Do you inject air in the AC? How about doing peripheral iodotomies? What is your take on that? For DALC?
Basically, if I have the type 1 bubble, it doesn't really matter because the Duas layer gives you a very firm scaffold. So you don't even have to open the eye until the very end if you want to. You can just dissect it off. But if I move on to the manual method, because I couldn't get the bubble, then I will make a peripheral paracentesis and let some fluid out and keep it as soft as possible. Because when you're dissecting manually and I use the Vanna, so I keep tunneling and I keep cutting, I don't want a convex cornea against which I'm working. So there it helps me to lower the chamber pressure, keep the cornea as soft as possible. And so it's not convex, it's a little flatter. So when I'm dissecting, it's a little easier. The other reason for making a paracentesis in the beginning, after you've injected it, is if you're not sure whether you've achieved a big bubble or not. I didn't go into the specifics because I thought this was more for general audience. But for them, basically, if you've injected the first time, you're not sure, there's a lot of frog eggs, you think you've got a big bubble, you're not sure, you don't know whether to open or not, then you can make a paracentesis and inject what is called a small bubble. So the concept being that if you have got a big bubble, the posterior cornea in the center is concave, isn't it? Because the air has pushed it down. So this small bubble will keep running around the periphery and you can see it. Then it's safe to open the roof, and when the air bubble decompresses in the type 1 bubble, this small bubble will come to the center. Whereas if the air you inject already goes to the center, then it means you don't have a big bubble. Then you shouldn't be cutting the roof. You have to keep making further attempts to inject.
Dr. Seema, you have a question?
Yeah, sir. There was an excellent point about refining from the top, the epithelial side rather than the endothelial side, to maintain the size of the graft. Would this be recommended only for keratoponic eyes where you want, or would you do that even for regular the other cases, not the keratoponic eyes, say for scars? And what would be a donor to host, sizing difference in the other cases, non-keratoponic eyes, say scar eyes?
In the other eyes, I basically punch only from the endothelial side, because I think there the cornea has a reasonably normal curve. So I don't think this precision in matching is that much required. Whether I go half more or quarter more will depend upon my assessment of the host margin. If I've managed a perfect 8 or an 8.5 host, where I've basically cut right out like in a PK almost vertically down, then I will usually oversize by half. But if I have, like in that case, I showed you a 9mm host where in the edge, I've actually had to leave a little stroma behind. So there is not a vertical cut, there's a little slope there. Then I may not oversize too much. I may go a quarter more so that I can fit it in easily. But in a keratoconus, the idea is to try and flatten a steep cone. Obviously, we are doing a DALC in a keratoconus because it's gone past cross-linking, it's gone past contact lenses. So it's obviously very steep. We're looking at a 58, 60 mic keratometry. So there I'd like to see if I can flatten that bed a bit. So there, if I can get not a 0.5 millimeter oversize, but a 1/4 millimeter oversize, it's good for me. But that I will only do if I can refine from the epithelial surface. If you punch a quarter from the host side on the, like you traditionally do, you could end up with a smaller, or the bed may be a little larger, and then you'll be pulling the graft here and there, and then you'll have horrible astigmatism.
Sure.
You refine it using an artificial chamber or how,
Yes,
doctor?
Artificial chamber and a vacuum refine on the top.
Do you inject air in the anterior chamber for prophylaxis, in the sense to prevent DM detachment or a Duas detachment on day 1, or would you do it only if required?
At the end of the surgery, there will be about a 60% airfill. Usually after I put my 4 sutures, for the cardinal sutures for the graft, I will put in an air bubble, because during all the dissection that we have done, we've often let out some air and the chamber is a little on the flatter side.
Right.
So when finishing the rest of the sutures, you'd like a physiological curve on the cornea. So after the first 4 cardinals, we put in about a 60% airfill, and that kind of remains until the end of surgery. So unless you had a perf or something and you want a tighter airfill in a standard type 1, 60% is more than enough.
Thank you. Thank you.
Just a comment, and I must congratulate Dr. Rao. I really enjoyed every time I listened to his talk. I had just a couple of suggestions, and this is something that we realized when we had initially started doing the anti-lamellar keratectomy. I think Dr. Rao touched on it. I think it does enhance, even if you remove 50-60%, it does enhance the success of the bubble. The second was the instrument that you use. I find that a 5cc with a 30 gauge somehow seems to give better results than a 27, even though we started with a 26, 27 gauge needle initially, because I find the pressure at the tip is an important part. Of course, the depth that you insert the needle or your cannula, equally important. I think the present cannulas with the bottom opening, I think, give a reasonable advantage. The third part is in terms of viscoelastic removal. Viscoelastic use for bubble dissection, I would agree with Dr. Revati. It's not maybe the most ideal way of doing it, but for your last dissection, when you release the air and then you inject visco, it does help with the removal of the posterior stroma. But an important point would be to make sure you wash away all the viscoelastic, because occasionally when I started doing it, I used to use HPMC, and that tends to crystallize if you're not very correct. So visco works well, but a Helon works well because it's easier to kind of remove it. I think the small bubble was something that has really helped, especially if you don't have access to an ASO-CTI. But the small bubble, I think, is a very smart thing to do. I think there is one, the AIMS group suggests actually injecting a small bubble before you inject the big bubble. even though for us, what we had described it was to put the small bubble after you've got the big bubble, just for that physics that you explained so beautifully. The ASOCT, I feel, at least for deep dissections, help you make a decision whether you really want to go all the way down. Because the obsession with going down does not, now we know with studies that even if you keep 20-30 microns left over, it really doesn't make a big difference in terms of vision. So even if you're down to the second last layer that is just above the DOAs and you got some micron left, you can basically safely leave it and patient will not have a compromise in vision. The only other point I would probably suggest is in terms of diseases. So the macular herpes, sometimes I find that the results are suboptimal with the DALC. So I prefer to do actually a PK and then manage it post-op.
The point about the cannula is well taken. I didn't want to complicate things, but for those who are starting it, I think a blunt, a closed end, bottom facing cannula is much better, because unlike the needle where there's always a little tentativeness about inserting it, you don't know if and the closer you are in the posterior stroma to the DM, the greater the chance of your bubble forming. So that you can do more bravely if you have these closed blunt cannulas. You have a little spoke, so you make a little entry to allow the blunt cannula to force its way in. And you generally stay in the mid-periphery. You don't go right to the apex of a keratoconic cornea, because there the stroma is so thin that you don't get enough counter pressure to separate it. That's just a small point. The thing about making a paracentesis at the start, I personally don't like it, because sometimes you can't control the type 1 and the type 2 bubble. If you get a type 2 bubble and it spreads right out and reaches the point where you've made a paracentesis, it's going to strip the whole DM off and it's going to keep tearing peripherally. So for me, it's always after the bubble injection, the paracentesis. I will never do it before for this reason. And the third thing about the macular dystrophy is if you're operating on a younger patient with macular dystrophy, and luckily macular dystrophies, unlike granular, will come to you fairly quickly. So if you're doing it in the 20s, either sub 20 or in the early 20s, oftentimes it works well. But once you're in the 30s, then I would agree with you. I think there's significant endothelial dysfunction in those people. And there, even if you're planning a DALC, you may be, you have to tell the patient that there's a reasonable risk that it won't attach. Or if like you, if you want to convert to a PK, you can. There's not much evidence about
have you seen recurrences, Dr. Rao, in macular dystrophy? Because that's a long, I mean, if you operate at 20, how are those DALC patients at 30, 35? I understand you can always repeat it, but
they get it back, which is one reason why you want to do it, because there is no literature, as far as I'm aware, which shows the recurrence rates are different between DALC and PK. Ideally, it shouldn't, because the keratocytes will repopulate both of these and you're replacing everything except the DM in a DALC. So they will come back. And in that case, it offers a beautiful advantage, because you can just strip that thing off and put a new one in, as opposed to a PK where you'll have to trephine all over again, risk of rejection and all that happens.
Thank you so much. So for want of time, we'll move to the next talk. We have Sujata ma'am. So Sujata ma'am is an alumnus of Tanjore Medical College. She did a DO from Shankar Nethralaya and she's a fellow of Royal College of Surgeons, Glasgow. She's currently the Associate Medical Director, Rajan Eye Care Hospital, Director, Rotary Rajan Eye Bank. Her special areas of interest is cataract, cornea, refractive surgery, and glaucoma. She has presented more than 150 papers in national and international conferences and has conducted over 100 CME programs. She has been adjudged one of the top women ophthalmologists in the country in 2009. She has received many awards and accolades, and most notable among them is Nari Shakti Pushkar Award, the highest women civilian award of the nation. And one more feather to her colorful crowded cap is currently she's the vice president of TNOA. And over to you, ma'am.
Thank you, Sharmila. I think you have to, yeah. Can you unshare the screen? Thank you. Thank you, Sharmila, for the wonderful opportunity given, and Dr. Nilmar as well. It's always difficult to follow a legend like SKR, but here I am. So my topic is on decimate stripping endothelial keratoplasty, or DSEK as it's popularly known. Just a heads up for people, for students who are watching this. So basically what we are trying to do in a DSEC is we strip off the descemet's membrane from the recipient cornea, and it's replaced with a partial thickness graft, which is consisting of the posterior stroma, descemet's, and endothelium. So manually, when you dissect it, it's called as DSEC. And when you have an automated dissection of the donor disc, it's called as descemet stripping automated endothelial keratoplasty, or DSAEK. So types of DSEC can be broadly classified into nano-thin DSEC, which is about 15 to 49 microns, ultra-thin when it is between 50 to about 99 microns, and thin DSEC between 100 to 149 microns, and conventional DSEC is between 150 to 250. This is all more theoretical, but there are a lot of people who do ultra-thin DSEC on a routine basis. So why DSEC when we had excellent results with the penetrating keratoplasty? The problem with penetrating keratoplasty was that the incidence of astigmatism was very high because of the differential healing and because of multiple sutures. Chances of rejection is also much higher in these patients. Rehabilitation takes a longer time because you have to do suture adjustment. Most of these patients may have a clear graft, but we may have to give them very high astigmatic glasses. And so this was actually a failure as far as the vision was concerned. And also other suture-related complications like broken sutures, which can induce rejection, or it can cause infection. The other important thing is if the patient has even a trivial trauma, the wound integrity is not as good as when you have a sutureless procedure. And also, more importantly, now we can use the same cornea into two parts, and you can use the anterior part for anterior lamellar keratoplasty and the posterior part for the posterior lamellar keratoplasty. So, but the disadvantage is it needs a little bit of training. You need good donor endothelium. So normally about 2,000 and more is what is required. And the indications are very limited because only if the endothelium is damaged, when there is no anterior stromal scar, these patients do well. The other important thing is that you have to be very good at dissection. So the risk of perforation during dissection can happen, particularly in surgeons who are just learning the technique. And postoperative interface haze is again a problem. In any interface or lamellar surgeries, this again is a problem. So the indications are Fuchs dystrophy, pseudophakic bullous keratopathy is the commonest. Aphakic bullous keratopathy, posterior polymorphous dystrophy, and postoperative descemet's detachment are again indications for DSEC. So Fuchs with cataract is probably one of the commonest causes for which we do DSEC. And so what we need is an artificial anterior chamber. I think Dr. SKR was just talking about it. So when you, what he suggested was when you're punching the donor, you use an artificial anterior chamber to punch it from the epithelial side so that you get the graft size that what you desire. So the same thing is done here, but we do it for a lamellar dissection. And for the lamellar dissection, we need dissectors. And what is commonly recommended is reverse teres straight and curved dissectors. So this is a small video showing how dissection is done. So the corneoscleral rim is mounted on the anterior chamber maintainer, and a partial thickness groove is made using a depth knife. And initially we make an entry using the sharp knife, and then you use a straight dissector. So it's important that you dissect at the same level so that you get an even graft, or the posterior stroma is even on both sides, and you go as far as the center as much as possible, and then use a curved one. So in this case, the left side, I'm using a crescent knife because the dissector was not working very well on that side, but it's a little bit of a risk. Now I'm using the curved one. The curved one goes up to the other side, and you can rotate it on both sides. Make sure that you get a very nice dissection, and make sure that you go from limbus to limbus. Because when you're going to punch, you have to make sure that it is completely dissected, so you get it into 2 layers. I'm marking this because I have not gone that far, so I just want to make sure that my graft, when I punch, is within this area. So then once you do that, you can punch it, and then you get into 2 separate layers. The anterior layer is the posterior layer, which we are going to use. So this is a case of a Fuchs dystrophy. You can see the corneal edema, and the epithelium is removed. and the phaco is done, it's very important that you do the phaco very effectively. You don't have produce any complications, because once you have a complication in a triple procedure like this, then it's going to be even more difficult to complete the procedure. So your technique of phacoemulsification must be top class. You cannot have a PCR, zonal dialysis, any such thing, so that you get the best results possible. And you get, but otherwise, other than that, the phaco can be done in exactly the same way what you would normally do, whatever you're used to. Then you inject the lens, and before removing the viscoelastic, mark the cornea and strip off the decimates. So the pupils are dilated, so you get a very nice view of the decimates as it's being stripped. So you use a Sinskey, reverse Sinskey for this. You can see that using the reverse Sinskey, particularly in patients who have fuchs, it gets stripped off very nicely. Sometimes in pseudophakic cases, you might have areas of scarring where you cannot get into one single bit of decimates, like you see here. You might get multiple strips. So now you go inside and remove all the viscoelastic. Make sure that you remove the viscoelastic even from under the lens. Constrict the pupil and do a peripheral iodoptomy, which I have done with using a vitrector. So now I'm doing the push-through technique. I've already prepared the graft and I've inserted it through the corneal incision, corneal tunnel. And the procedure is done. Then you inject air and apply a suture. It's very important to have good air control, because what happens is if the air goes down very early, there's a chance of dislocation. So it's very important to make sure that you have enough air. And what I normally do is I wait for at least 10 minutes for the patient to lie down in the operation table, and then slightly burp out the air, but to keep at least about 70 to 80%. I'm quite confident patient will not develop a pupillary block because we have made an inferior peripheral iodotomy. And once that is done, the procedure is over. So this is a case of DSEC in a pseudophakic bullous keratopathy. Here you can see again the epithelium, which is already become scarred, is being stripped off. Normally in these patients, we inject pilocarpine. You can use air, because if you use air, your visibility of the endothelium is much better. Or keep the pupils dilated. If you keep the pupils dilated, then you get a very nice red glow. Or use air, because using air, it gives you the advantage of seeing the endothelium very clearly. You can alternatively stain the endothelium also, but the best thing would be to use air in the anterior chamber. And also a retro glow will give a good idea about if you've stripped off all the decimates. Again, do an inferior PI. You can do it manually or you can use a vitrector, and completely remove all the viscoelastic from the chamber. So again, here what I'm doing is a push-through technique, and the graft has already been made, and I'm using a cystitone to push it inside and unfolding the graft. You can actually just tap on the graft and center it. You really don't have to use a Sinskey hook to pull it inside. But sometimes, because of the graft host mismatch, the curvature, it may not come to the center, in which case you have to pull it using a Sinskey hook. So this is a case where I've combined a glued IOL along with an SFT. Like I told you here, air management is very important when you're doing lamellar procedures. So here I'm making two flaps, scleral flaps for the glued IOL, and also a scleral entry. So multiple entries have been made. This is for to facilitate keeping an anti-chamber maintainer, and also for the glued IOL. So now the IOL is being injected, multiplease IOL is being injected, and it is retrieved from under the sclerotomy, under the flap, and the other side is also it's retrieved. A Chariot's pocket is created to tuck in the glued IOL on both sides. And once the IOL is in place, You see the pupil is very large, so we have to do a pupilloplasty to constrict the pupil. Otherwise, what happens is in these patients, the air will move behind and the incidence of graft dislocation becomes very high. And this is already a vitrectomized eye, and so it's likely to be very soft, and the incidence of dislocation is much higher in these patients. And so it's what I've done is I've constricted the pupil to about 5 millimeters so that there is some control of air when you inject it. So you can see that I've made a loop and passed the end of the suture 4 times through it. So this is called a single pass 4-through pupilloplasty. And now I'm measuring the size to see what size I'm going to put the graft. So again, Descemet stripping is done using the reverse Sinskey hook. You can keep the anterior chamber maintainer on, or you can inject air. See, you can see that while we inject air, you're able to, the visibility is much better. And the Descemet is stripped and removed completely. And here I'm making venting incisions because what I'm scared about is that because it's a very soft eye, the chance of graft dislocation is high. So now this again, the graft is introduced and air is injected. In very soft eyes, you have to take extra precautions and make sure that you have a complete airfill. And that you can do if you have an inferior peripheral iridotomy, as we have done here. And the peritomy is closed using the glue. So this patient had excellent results. So these are, just skipping this video, I'll skip these 2 videos. So these are some of the patients who had DSEC done, the pre-op and the post-op. I see some of the patients have post-op photos. So the important thing is to minimize donor trauma so that the loss of endothelial cell during the surgery is reduced. So making wider incisions to reduce compression during insertion is one such technique. There's a report which says that 40% of cell loss occurs in incisions which are smaller than 3.2 millimeters versus 27% in 5 millimeter incisions. Whatever may be the technique of insertion like glide, pull through or push through, it really did not matter. And of course, surgical experience did matter. So advantages of DSEC are the recipient cornea remains structurally intact. It's more resistant to injury. Recovery of useful vision occurs early. Preoperative refractive status, that is one very important thing because the patient's refraction does not change much. Maybe it might become a little bit hyperopic. Visual fluctuations are minimal during the healing process and no suture adjustments are required. Complications are the commonest complication, the immediate postoperative period is graft dislocation. It's very important that we look for it. So on the first post-op day and the 3rd or 4th post-op day, you have to do an anti-segment OCT to make sure there is no graft dislocation. Very minimal separation, you can leave and watch. But if there's a large area of separation, it's better to rebubble. So if you have a graft dislocation, you can have a primary graft failure. Also, graft rejection, though it is much less than penetrating keratoplasty, is one of the complications. And cell loss, because of poor technique, is again one complication which can lead to primary graft failure. So graft dislocation is a commonest post-op complication. It can range from 4 to about 24% in different studies. It can be managed very effectively by a rebubbling procedure. And here they found that the success rate was anywhere between 64 to 96% in various studies. However, every time you rebubble, there's an increased risk of endothelial cell loss and graft failure. So this is a small video showing how rebubbling is done. So actually you can see that as I'm entering, the graft is actually moving further away. So I'm using the same instrument to center it because I don't want to make another opening. Here, I'm making sure that there's some air underneath so that my instrument doesn't touch the endothelium as much. And now just hold on to it for some time and close the incision with a cotton bud, making sure there is no leaking of air. And make a complete fill. That is very important, particularly when you're doing rebubbling. If the patient is a high-risk patient, then you can use a non-expansile C3F8 because air remains in the chamber for only a couple of days, whereas C3F8 will remain for at least a week. And so that gives a more chance of attachment of the dislocated disc. So high-risk patients are patients who are aphakic, vitrectomized eyes, patients with leaking incisions. So this is something that we have to look at because some patients have a habit of squeezing. And if you've not closed your incisions airtight, then the air can leak through the incisions and that can cause your graft to dislocate. And also eyes with large distorted pupil, the air can go behind the iris and the tamponade will be lost immediately in the immediate postoperative period. So these patients, we must ensure that the supine position has to be maintained at least for 24 hours. The other important measures are scraping of the peripheral donor bed to make it more, to give a better scarring effect, complete air tamponade, and then, like I told you previously, supine position postoperatively using venting incisions, which I showed you. So venting incisions have a risk of epithelial ingrowth. And so if you're going to do venting incisions, better to remove the epithelium on top. And this can be done in patients who have very soft eyes or post-vitrectomy. So these patients, so that the dislocation rate is reduced. And also making sure that all your incisions are airtight and suturing the side port incisions if they are large. So conclusion is that lamellar keratoplasty is here to stay. And with more and more corneal surgeons shifting to DMEC, with even better results, indications of DSEC is reduced to complex cases. Thank you.
Thank you very much, ma'am, for your amazing talk. That was very clear and very beautiful videos with nice outcomes. So I come to your last slide, ma'am. When do you decide to do a DMEC and not a DSEC? So what are your indications for DSEC?
See, if I see a patient with fuchs or with a pseudophakic bullous keratopathy, with no vitreous loss, pupils round, and then probably we can go for DMEC. But if the patient already had a complication, large irregular pupil, and lens tilted, so those sort of patients, I think there's a high risk of dislocation of the graft in DMEC, because in DMEC, you have to be very careful about air bubble, because you need the bubble to stay for a longer time. The other contraindication in my case is that I would not do in a scarred cornea. When I'm doing the Descemet stripping, if there are areas where I can see tags, if I'm not able to strip the Descemets like a thin sheet, then those cases definitely for me would be a DSEC case. Because over the past decade, but more than 10, 15 years, we've been doing DSEC, and our results have been very good. The only recently I've shifted to doing DMEC, so definitely I have a little bit of restrictions, and I in complex cases like vitrectomized eyes or patients who have had already multiple surgeries, post PK DSEC, post PK keratoplasty, those sort of patients I would rather do DSEC, because in post PK cases we cannot stick the Descemets, and we do end DSEC, which we cannot do with a DMEC. So these are some of the indications where I would prefer to do a DSEC than a DMEC. And
this question is for Sujata ma'am as well as for the other panelists. So do you do a pre-op, you prefer a pre-op laser iridotomy or an intraop? Ma'am showed all intraop iridectomies. So what is
intraop? I do intraop, because see, one thing is that we will not be able to see so clearly for doing iridotomy. Some of them have limbus to limbus corneal edema. That is one reason. Another reason is I'd like to have a large iridotomy. I want to make sure that the iridotomy is patent. We cannot have very small iridotomies like we have for, I mean, at least from my point of view, I'd like to have a nice one, nice large one, at least 1 into 1 millimeter.
What about the others?
Yeah, I also agree with ma'am that mostly it's only intraoperative iridotomies and also positioning it inferiorly to these patients.
Yeah, I too prefer, but there are some cases, even I tried, and I have read, I think, an article by Dr. Price. You can do without PA also. Because in most of the cases, like at the end of the surgery, you can wait for some time. And what I do, another step is I use, when the patient is lying on the table, another 10 minutes I keep and I apply glycerin on the corneal surface so that it will desiccate the thing and it will attach the graft also well. Then I release the air bubble a little bit. I won't send them away with full air bubble, most of the cases. But of course, whenever I have some complicated cases, I used to leave the air bubble full. In such cases, you can do away with PA also. That's what that paper says. And I tried in few cases. They were good, but now not that always I don't do. I do.
So you go up the air again in the theta.
Yeah. I'll
Yes.
ask one
So as
question.
far as PA is concerned, there's one thing that I would like to add, especially in cases of DMEC. So this happens in, it may happen in DSEC also, but the one thing we need to be wary about in endothelial keratoplasty cases is to avoid intraoperative fibrin or blood clot formation in the anterior chamber. That is extremely imperative, especially in cases of DMEC where you want the graft to kind of unroll. So if there is any fibrin or blood clot going around in the AC, that causes sticky areas and which will prevent your graft from opening up. So if I realize in the preoperative period that there is going to be a lot of pigment dispersion or FM formation intraoperatively, I would like to do a preoperative YAG-PI if the visibility is good enough. Okay, so that is the one point. So if it's like a post-chronic uveitis corneal decompensation or post-TAS eye, which a lot of pigments have been dispersed, such cases an inferior iridotomy preoperatively, size could be bigger, okay, but then that would be probably preferable. Otherwise, in all cases, yes, we'll go for an intraoperative surgical PI. And the other one point I would like to just for the benefit of beginners. So when we insert the graft during DSEC, we have, if it's the push through kind of technique, we have a layer of viscoelastic on the surface of the wound, and we push the graft through for it to glide inside the anterior chamber. It's very important to understand that this is when the endothelium is facing down and the disc is completely open. If you're inserting with the disc folded, that is, you have a fold or a taco kind of technique, you should definitely avoid any visco on the surface of the wound, because the surface which is now exposed to the visco is the stromal surface. So if the stromal surface gets any visco, it is very difficult to wash it out, and that will cause persistent graft detachment issues because of visco in the interface. So that's a very important point.
Yeah.
So, yes,
I'd like to ask one question to Dr. Sujata ma'am. Actually, beautiful videos all which you demonstrated. Can you enlighten us on the graft sizing? Is it variable for, how would you judge on that?
Yeah, see, what I do is if I find that the AC is very deep and I have enough space, I would put an 8mm graft. That's why you saw me measuring. Most of the patients I measure to see what will be the ideal size. But if the AC is shallow, then I would put a 7.5mm. I've not gone less than 7.5. Normally it's 8 or 7.5. So I measure that if it's smaller eyes, I'll go for a smaller graft, 7.5mm.
Revati ma'am?
Yeah, I too. I don't prefer very small grafts. I too, usually it will be around 8. Even 7.5 is a little rare only for me. Usually it will be maybe in a post PK or something like that. We may be restricted by the size of the previous thing and the graft host junction scar. Otherwise, I prefer at least 8, and I do like that. And I most of the time I do ultra thin DSEC, so that 2-layer dissection in the artificial anterior chamber, so that I can make it as thin as possible.
Ms. Sir, you would want to add something?
No, I had a question. If anybody had used, there was one, I think about 8-9 years back, where people were using the rim of the dissect and the central part became very thin. They were using a bubble to kind of dissect and keeping the rim. That was called an S dissect. Has anybody actually used it? Because for me, that seemed to give both the benefits of both the techniques of
Once
DMEC
the
and
DMEC approaches have solidified and they have matured, I think that's been given up. Because initially it was to serve as a carrier for the central decimase, but now that the DMEC itself is now very evolved and everybody is doing it, I think that procedure is gone. I think there's a few things. One for me is I always use hyaluronate in my D6. I don't use HPMC at all, because if you're going to wash it out, it's easier to wash out hyaluronate. I guess you can do it with HPMC. I know people who are experienced use it, but in my hands, I think hyaluronate works better. I use a S stamp even on my DSEC grafts. After I've done it, I will flip it and I will use an S stamp. And I don't do PIs, honestly. Sanjeev does them for all his DMEX, but I don't do them for my D6. If I have a complicated situation like what Sujata was saying, then I do venting incisions, basically. I remove the epithelium anyway, so it's quite safe to do it. So I will do vents, and that helps me get rid of the interface fluid. So I almost never do a PI. So we put in a full fill, and I don't have the patience to sit in theater for 10 minutes and release anymore. So we push, we go down, send them down, and we burp it at the slit lamp 1 hour later, if required. So that is what we do. The sizing for me as well is usually 8 or 8.5. I seldom go smaller than 8. The issues with sizing are I will measure the white to white on the host. So sometimes they have small corneas, 10, and then I will go 8. But if they have a large 11 millimeter cornea, then I will try and get in an 8.5 because I want to get as much of donor in as possible, obviously, provided they don't really have a very shallow chamber, like she said, or if they don't have peripheral anterior synechiae sitting somewhere. So then that would be the thing. And also about the thickness of the graft. So after I've dissected it, before I go in, I will look at it on the in the block itself, separate it and see. So the thinner the graft, the larger the graft I will take, because the thin graft tends to hang off the cornea and gets closer to the peripheral iris. And that's when you have a higher risk of PAS. So to do an 8.5, I need a big donor eye, a big host corneal diameter, and I need a thin graft. And also in the graft, when you dissect it, the donor itself sometimes will be very small. It's only a 10 millimeter donor. So there you cannot really punch a good 8.5 because you've gone in the periphery with your manual dissection. So you lose about a millimeter there when you're getting into the correct plane. So these things come into play, but generally it's between 8 and 8.5.
Just a query and a question to the panelists. Ultra thin manual dissects, have you tried that?
Yeah, that's what I said. I do routinely. I do the artificial chamber, first dissection.
Not
Then
with the keratome. You're doing it one.
Same keratome, same. Then at the sides, I'll extend the pocket and then reflect it, and then I do another layer where you can see and judge. So most of the time I get very thin thing. Almost they behave like DMEC buttons when you inject, when you push it in.
And when you're inserting these manual thin dissects, do you use a pull through or do you push it?
No, same pushing technique only I use because there will be some stroma. Sometimes I use, instead of stitchitome, I use only the Sinski to push it in. And then they will again, they will behave like DMEC. They will fold towards the endostroma. Then you can keep the anterior chamber slightly shallow and then nudge them to the center and inject the air.
Because the experience that I've had with a couple of the manual dissects was the periphery started over a period of time. Once the edema disappeared, the periphery in one edge started folding up. So I had to go back and suture it. So that's one thing that I find slightly tricky when really thin. It's almost, as you said, behaving like a DMEC.
Okay, but I have not had that problem so far. Maybe it's just you keep on try, or maybe the training corneas, no? You keep on try doing this double dissection, then you will have the hang of it, like how deep you can go, how to maintain a uniform interface, thickness.
Want of time, we'll move to, thank you everyone for the wonderful panel discussion. We'll move to the next talk. So we have Anand Parthasarthi sir, who is currently the director, chief surgeon at Center for Vision and Eye Surgery, Chennai. He was a director corneal and refractive surgery service at the Vasanayake hospitals from 2006 to April 2015. He has performed over 50,000 ophthalmic procedures and is trained in Aravind Eye Hospital, LVPI, Singapore, and Germany. He's the chief instructor and co-instructor for cornea and associated and invited panelist at the ACRS, APO, ECRS, and the World Ophthalmic Conference and the SARC Academy of Ophthalmology. Over to you, sir.
Thank you so much for allowing me to be a part of this lovely discussion. I'm learning so much here. And I must say, I have a lot of regard for co-panelists who've taught me so much as I continued my cornea journey. Is my screen visible?
Yes, sir.
Okay, so before I go ahead, I think it's important that we just differentiate and know what the full forms are, because PDEC is pre-descetic endothelial keratoplasty and DMEC is Descemet's membrane endothelial keratoplasty. And just a small nugget, when I actually started researching endothelial keratoplasty, which was in 2004, 2005, the term that I got on Google was not related to keratoplasty alone. It was totally unrelated. So what we did was we actually looked at corneal, looked at 60s and 70s with respect to preferences of corneal surgeons. And what we found was the choice of procedures has changed according to the preference for the present look of our film heroines. And that's probably what has changed as well, where we find DSEC, DMEC, and PDEC said to be a preferred option, definitely for early endothelial changes. And when you look at endothelial keratoplasty alone, it actually did not start directly with DSEC or DMEC. It started with DLEC, which is no longer done, where there was a dissection both on the recipient stroma as well, and you kind of fitted it in with about a dissection pocket where you fit in the DLEC graft, which is then evolved into DSEC and DMEC. And I'll just spend a bit of time because on this important part, because this is probably the crux. What is the difference between DMEC, PDEC, and DSEC? And it's probably with respect to small points about graft size, the type of the bubble, the donor age, surgical layers, technical difficulty, donor tissue, and the type of procedure in the first part. We do know that PDEC tends to give smaller grafts because we are trying to get the type 1 bubble. The graft size in DSEC, at least in Western eyes, though in Indian eyes we restrict to 8, 8.5, can go up to 10 as well. The donor age, I think, is an important part because in DMEC we do prefer more than 40 because it's probably very, very important in terms of unrolling of the descemetes, because there is a change in the nature of the descemetes as a person grows older. While in PDEC and DSEC, it's independent of the donor age. The surgical layers that are actually transferred in DMEC is the descemetes and the endothelium. In PDEC, it's the pre-descemetic or DUA layer with the descemetes and the endothelium. In the DSEC, as Sujata mentioned, you're transporting a lot more. In terms of technical difficulty, I would probably put DMEC as a slightly higher learning curve, and that is tissue loss. In DSEC, the chances of tissue loss are usually very minimal unless you've had a dissection in the preparation itself. And what does it actually affect is DSEC, as Sujata showed, is a tissue additive procedure. It does cause a bit of hyperopia. In PDEC and in DMEC, the change is very, very minimal. In fact, there are some studies where they are almost tissue neutral. Artificial chambers, of course, required in the DSEC for the dissection. You have automated versions for DSEC. I'm not very sure about the PDEC, but that seems to be some clinical trials going on. IBAG prepared donor tissue is possible in all three. The graft unrolling, which is a very important part of the procedure, is a lot more difficult in DMEC because of the slightly thicker PDEC graft, the additional 12, 15 microns. It does help. In the DSEC, it's a lot more easier. Tissue handling, probably a lot more fragile. I'll not say difficult, but fragile. The descemet's membrane does tend to tear off, while in PDEC and DSEC, it does allow you a bit more of manipulation. The visual recovery in the DMEC and PDEC is a lot more faster, but with, I guess, the ultrathan DSECs, the visual recovery would be very, very slower. But in a standard manual DSEC, it does take about a month, month and a half to actually improve. There have been some studies comparing PDEC and DMEC, and we know that, of course, the grafts are smaller. There can be peripheral adhesions, and because of which the PDEC graft cannot become bigger than 8. As the DMEC is larger, it tends to cover a lot more area, and the endothelial cell loss is almost similar, and that's an important factor. Now, I will touch upon PDEC first, and I will then go on to DMEC. And I will mention a bit of the important parts about PDEC, which is the bubble, the air-assisted PDEC, the E-PDEC, which is with the endolight, and the graft unrolling. Now, this has been discussed extensively in using type 1 and type 2. Just to suffice to say that the PDEC, the preference is for the type 1 bubbles. What is the type 1 bubble? Is the bubble starts from the center, and you can extend it up to the 8 millimeter. So this is the type 1 bubble. This is what is preferred in terms of using it for the donor. You can get a type 2 bubble very occasionally where it starts from the periphery and then extends to the center. These grafts cannot be used for PDEC, at least in the initial use, because the chances of handling is very difficult. You can probably use this for DMEC if you're reasonably experienced. Occasionally, you can get mixed bubble. Here you can see that the periphery started expanding with the type 2. You release that, you can actually go back in and then inject again, and you can get a central big bubble again. This may require multiple injections. You may require, just like DAL, to inject a couple of times in different positions. The position of the needle needs to be needle up, the bevel up. It needs to be pointing towards the descendants. There is one concept of air-assisted PDEC in which an antechamber maintainer is applied, and then air is pressurized. This then helps with the descemetorrhexis. And which are the basic parts of the technique is the descemetorrhexis, the graft rotation, the graft edge unfolding, the graft unwrinkling. With the air, it basically promotes graft adherence. The air basically prevents AC depth fluctuation. It holds the graft up. And in case you are doing a PI, it tamponades the eye without any chance of bleeding. It prevents the ooze because this can affect graft adherence. Now, in a peripheral graft, you basically fill in a full fill. The advantage of using air is basically that you see the edge of your dissection, and even for DMEC, you can dissect, you can use this. The removal of the graft is a lot more cleaner. There's a very, very less chance you will leave any descemetes behind, because the visibility using air is a lot better. The EPDEC, which is something described by Susan, is where you have an endoilluminator kept obliquely at the limbus to shine the light into the antechamber, and the tangential light now allows good comprehension of the graft, and the oblique incident light basically gives three-dimensional perception. And I'll just show you a video to demonstrate that. Now, this is actually showing if you have an OCT, it's of course a lot easier to know the roles, but if you don't have this light alone from the periphery, tells you the orientation of the graft. And in this, the roles are towards the endothelium, and you can actually go ahead and open the graft, unfold the graft, and then complete the procedure. Now, the graft unfolding, both for DMEC and PDEC, is an important part. It is, of course, to make sure you have the orientation. You can use a reverse Sinski, you center it, and a bit of use of fluid currents, a corneal massages performed to adjust the centered position. Now, this is in an edematous cornea. You need to make sure that the staining is good. I prefer this level of staining where you basically tap, open it up, and then push in air. Now, the advantage with the PDEC is you use the reverse Sinski and you can actually manipulate, which is slightly more difficult with the DMEC grafts. The PDEC grafts give you a bit more of manipulation room, which you can, if you want, you can adjust the graft a bit. You can combine procedures with DMEC or PDEC, where you can do glue IOL, you can do pupilloplasties as well, which help to keep the air bubble in place. Now, in all patients, a good idea would be to keep it for do an inferior PI, keep the air bubble in at least for about 10 minutes on table, and then if you want, you can take it down to the OPD and burp it if you want, or on table itself. This is a lovely video of DMEC itself by Dr. Siddharthan. Very elegantly demonstrates what are the important parts, where you refine with a 10mm graft, you go around and mark out the graft itself, and then use a good fine-tooth forceps to remove the descemetes. Now, this is the classical descemetes membrane DMEC procedure, where you refine the anterior stroma, and then you float the graft back, turn it around, remove the cap. You mark either S, P, or L, whichever is your preferred letter, and then refine a smaller graft, which is now about 8 in this case. Put it into the holder, and there are multiple modifications. You can use the glass injectors, which I prefer, or you can use plastic modifications of the IOL injectors, where you modify the IOL injectors. My preference is for glass, because I find stickiness is less in plastic. The graft tends to stick a bit. You use the injector and make sure the orientation in the injector is correct before you inject. You can use a 2.8 or a 2.2 incision. You inject it into the anterior chamber. Make sure you suture the main port. And once you have it oriented either with the cigar roll or with a double roll, like in this case, is a lot more easier. You need a flat chamber so that you can flatten it. You can go with the use of double cannulas or 2 cannulas, use fluid currents, tap it, go in again, use an air bubble to actually then attach the graft. And this is more or less the end of the procedure. A PI can be done preoperatively or can be done intraoperatively. I think preoperative sounds a lot more a good idea, which was discussed earlier. The advantage with the DMEC is you have a very, very clear interface. There is no chance of haze in the interface, which occasionally you do get with DSEC or in advanced bullous keratopathies. Can work very well for failed grafts in this patient who had a surgery done for PK about 4 years back, came back with a failed graft. A DMEC done showed improvement. So you can, the advantage is you can, if you want, repeat this as well. Now, is there a difference between PDEC and DMEC? And there is one published study which I could trace where they found that DMEC graft was significantly thinner, almost at about 16 microns versus 27 microns. That is the 10-12 microns, which gives you the ability to manipulate the graft. The endothelial cell loss, very similar. The rise of intraocular pressure on follow-up, very similar. So if you are looking at visual improvement, you are looking at the long 6-month follow-ups. I think both are very similar. I think different surgeons prefer different techniques. I guess the people who described the PDEC, which was from the Agarwal group, prefer PDEC to DMEC. I have not seen them do DMEC or talk about it. DMEC is probably preferred by majority. I think probably about 85-90% of the surgeons who practice it. And now, since the protocols of DMEC are a lot more confirmed, I think in terms of visual results, both would be the same. And I think it's a personal preference. Just to last slide or take home pearls, that thinner grafts, you do tend to get better vision. There are lower rates of endothelial rejection, been described quite deeply. Sharper learning curve than DSEC, because DSEC, I guess, in terms of number of grafts, probably 20-25 in terms of making sure you get good consistent results. Probably, at least in DMEC, you're at least looking at the similar number of grafts, or probably more, because there are 2 or 3 critical steps in DSEC, DMEC and in PDEC, which is the graft preparation and the injection. A more endothelial damage, I feel, is probably true in the learning curve for these surgeons, especially if you are shifting from DSEC. And I think my understanding is that you'll it's not a progression from PK to DSEC to DMEC, PDEC, but these 2 surgeries are totally different. The set of skills required are totally different. So you treat it as a new surgery itself. It may definitely help in better graft utilization because you still have the anterior stroma to use it for patch grafts or even for a DALC. And there have been some studies which did describe that. I would like to acknowledge some videos which I borrowed from colleagues. And thank you so much for your attention.
Thank you so much for the excellent talk, amazing videos, and you clearly differentiated, showed the differences between PDEC, DMEC, and how to create it and all that. Very nice talk, sir. I just request the panelists to go for the discussion.
So this is just one point, Sharon, regarding irregular pupils and endothelial keratoplasty. So I feel that whenever there are irregular pupils, that is the one thing which prevents the air to stay properly in the anterior chamber, which is very, very essential for a thinner graft like a DMEC graft or a PDEC graft rather than a DSEC graft. So in case there are pupillary irregularities, one thing is for beginners is always better to go for a DSEC rather than or say there is peripheral anterior synechiae or something. Better to go for a DSEC than a DMEC, but in more experienced surgeons' hands, probably correct the pupillary defect before, like it has been discussed by the speakers about doing a pupilloplasty of any kind, and then go in for a DMEC. In complicated cases, it will always be better to do the graft dissection after doing the host preparation. So when you're doing the host preparation, you'll always have an idea as to what are the challenges you're probably going to face intraoperatively, and then you want to make the decision whether you want to go ahead with a DMEC or a DSEC. So preparing the graft to begin with, you may after when you're doing the host, you may find that DMEC is not a possibility in this case, in which case you would have lost, or you will have to keep the graft for another day. So that can be avoided. And the other thing about combining, aphakic eyes along with endothelial keratoplasty is you can do an SFIOL or a glued IOL, whatever is the preference. But in these cases where DMEC or PDEC is a thin grafts, all these cases, when you do an SFIOL or such procedure, you'll have to do a vitrectomy and then place the IOL. The anterivitreous space is kind of getting affected, and your air has a propensity to go behind the iris and into the vitreous. So a lot of times you'll struggle with the air staying in the chamber. So it's probably, if the iris is in good shape, the other option would be to do an iris claw IOL, where the IOL is very snug with the iris plane. So it functions like a lens iris IOL iris diaphragm, which then keeps the air well in the anterior chamber, if the iris is in good shape, that is. And you don't have too much. Having said that, if you have too much of iris manipulation during a DMEC, again, that will cause fibrin formation, which we already discussed. Thank you.
Yeah, I think good points, Seema, thank you. I feel that in combined procedures, I didn't discuss it because that would have been fairly long, but a very valid points in terms of aphakic bullous keratopathy, where you need to manage the lens, you need to manage the iris, because these tend to be complicated cases, and then you're looking at the endothelial part. I feel that iris claw is my now preferred option, because I went through the procedure of trying to do it with the SFIOs. I found that the vitreous tends to absorb most of the air, and then you have a struggle with the graft. So now I've just modified the technique a bit, wherein we have a double infusion technique, wherein we fill the vitreous with the vitreous standard vitreous infusion. For the anterior part, we have two basic infusions. For the anterior chamber, you finish your IOL procedure with the anterior chamber infusion. You finish your vitrectomy, you push the IOL. For the posterior part, if you need for the air to make sure that doesn't go back, you have an infusion in the posterior chamber, and that basically helps to maintain its pressure. So when you're putting in the air, it doesn't escape into the vitreous. So these two modifications for aphakic bullous keratopathy are important, where you have a vitreous full of saline rather than a soft eye, because the chances of detachment, especially in aphakic bullous keratopathy, probably slightly higher. Just my personal anecdote, that I do find that if the eye has a slightly longer axial length and it is a fairly more traumatic first surgery, the chances of detachment, either DMEC or DSEC, tends to be higher.
So this posterior infusion is what you use for DMECs as well, or is it for DSEC?
For any combined procedure. I haven't done combined procedures of DMEC with SFIOL yet. At least I haven't tried that. I prefer DSEC for such
it to be difficult. Yeah, posterior infusion saline would cause probably difficulties in graft opening.
This is for DSEC.
For DSEC, yes, I agree.
And for combined procedures, phaco endothelial keratoplasty, do you prefer a hydrophobic IOL always?
I think so. I think that's been proven because of the opacification of hydrophilic IOL, which occurred with long air stays. So I mean, if you ask me which would be my preferred, which you got such a large opening, I would actually prefer PMMA in most of these cases, unless you're doing a phaco DMEC or a DSEC, where you could probably put a fold.
Yeah, so that's what I agree to. It would be either a hydrophobic acrylic or a PMMA. I mean, PMMA would be a go-to in these cases. Another point of combined cases is your IOL power calculation, wherein you will have to, one thing which is well documented in literature is the hyperopic shift that happens after DMEC or DSEC, more so in DSEC because the tissue add is more and the posterior curvature is going to give you a more convex, which causes a more hyperopic shift overall. So you anticipate that and go for say a diopter higher IOL. But having said that, you have to keep in mind that most of the cases that we in our population come across is not these very nice looking Fuchs cases, but very, very, difficult cases of PPKs or kind of near scarred corneas, wherein the anterior surface, the keratometry reading to begin with itself is very difficult to get. So when in these cases, I would always prefer to probably strip off the epithelium in the OPD itself, remove the epithelium, and then do an A scan to get a better keratometry, and then go for your IOL power calculation.
That's a
in
nice
contact
suggestion,
lenses.
actually. I haven't done that, but that's something we could think.
I have one question for the panel. Like in a case of a long-standing aphakic bullous keratopathy where the patient has been asymptomatic for like 20-25 years, and now they come with the bullous keratopathy, would you like to combine with the IOL or just do a DSEC, or what would be the preference?
I would probably, for me, a long-term aphakic bullous keratopathy, for me, a primary consideration may be the intraocular pressure, because the chances of glaucoma is something which probably needs to be ruled out. But if you are able to see the disc, it's an early decomp. I would definitely try and see if we could use any of these rho kinase inhibitors first. But if it's way beyond that and it's a very edematous cornea, I would definitely plan for a combined procedure. And in a aphakic bullous keratopathy with the history of vitrectomy, I would definitely plan for a DSEC with an SFI. Or DMEC may not be, at least in my hands, not the first procedure.
Revati ma'am?
There are many factors we have to consider. Is it the only eye, or the what about the other eye? And also, how is the iris and how is the iris and pupil and all? Based on that, only we can decide whether we need to put a secondary IOL and then go for the. Sometimes I just leave them as a aphakic, and but in those cases, I would prefer if at all a DSEC or a PK, especially in a very elderly person.
Yeah, very elderly people who cannot lie down for a long time. In position, chances of rejection also is much less. In this.
Less, yes.
So instead of troubling them so much, and it's better to do penetrating keratoplasty in these patients.
Dr. Rao?
I would agree. If the other eye was not aphakic and had useful vision, then I would prefer to put in a lens because of all the air management issues. Yeah, so I would, and for me, my preferred technique is an SFIOL. That's what I'm most comfortable doing. So the only question for Dr. Seema, if she's still there, is have you used any heparin in these fibrin cases in the DMEX, in the AC? Have you ever had a chance to do that?
Muted. Muted, Seema.
Muted.
Oh, sorry. That's sorry, sir. I was on mute. So yeah, this is the point I've been discussing with colleagues as well. I haven't used heparin as yet, but it's really probably worth trying using heparin in these cases, because the only times when I've had to convert my DMEX to a DSEC is not because of graft preparation failure, but because of fibrin in the anterior chamber. The blood clot or fibrin. So heparin probably worth giving a try. I haven't used it yet though.
There are some studies which show that they use enoxaparin in the drip in these patients. In all the patients, there are some surgeons in the US who use heparin in all the patients who are undergoing DMEC, because they feel that the tapping on the iris is the cause for the release of fibrin, and so it's better to use fibrin for better adhesion.
Yeah, and this one thing where when you have this intraoperative bleed, especially it happens when you make that PI with a vitrector or say with the Vanas also, and if you feel that you want to tamponade the bleed with an air, by the time you prepare the graft and come back, you put air in the anterior chamber so that it tamponades. Actually, when you come back and you remove the air, you'll see that whole air would have acted as a scaffold for the fibrin to form and completely block the pupil as well. So even air to tamponade the bleed doesn't really work very well in these cases. So yes.
Thing is that I've used this deltaparin long ago, I think 25 years ago, when we were doing the pediatric IOLs, because we didn't have these heparin surface modified lenses so freely available. We didn't have foldable lenses. Talking about rigid lenses. So in children's eyes, when we were doing the open sky, the large incision technique, 6 millimeter incisions and so on. So routinely used to use it. So in a standard pediatric cataract, no problem. But if you have a traumatic cataract where you're having to manipulate the iris and all, we quickly learned that leaving this in the eye can cause a hyphema the next day. So there we wouldn't use it. do the surgery. And then if you've not done too much iris meddling, if you're not having any ooze, then we would finally wash the chamber and leave some heparin in the eye at the end of the traumatic cataract surgery. So I don't know whether that applies here. Fibrin, yes, I agree. But if you have an active leak, then I'm not sure whether that will have an issue.
What would be the concentration that you would use, sir?
We were using, I think the deltaparin, the thing was 50 milligrams, the vial, the syringe, it was an injectable. So we would just add it to the 500 ml of saline. I think it's the same now. There, enoxaparin, I think they're talking about 40 milligram per ml while adding it to your bottle.
Does anybody feel that it is better to use BSS only for all these cases rather than using, say, a ringer lactate or something that you would generally use for a cataract surgery? Would you always stick to using BSS, or what's your take on that, sir, for endothelial keratoplasty or DMEC cases?
I don't know any data that works that way, but I only use BSS anyway. So for me, it doesn't matter. I don't use the other stuff anymore. So I only use BSS. So I really don't have a comparative answer for you. But having said that, we used to use ringer lactate for our PKs for years together. And we didn't really see any endothelial toxicity from it, extra endothelial toxicity. So I'm not really sure if it matters, but I personally haven't done D6 with RL.
But again, the advantage with PK is because the graft manipulation is very less. So most often it's very well maintained. So whereas in DSEC and DMEC, it depends upon how much of manipulation goes into the surgery itself.
One more question for panel discussion. How frequently would you like to rebubble the DSEC or the DMEC graft? And how early would you do post-operatively, or how late would you prefer to do?
See, if it's a good separation, first day the separation is quite large, then it's better to rebubble as early as possible. But if it is in a very small area, say about 1 or 2 millimeters in the periphery or wherever it is, we can wait and watch. Most of the times it sticks, it just gets absorbed and sticks. But in patients who have, for example, a patient who's had a DSEC post-PK, then it's better to rebubble because there'll be a graft-host mismatch as far as the curvature of the graft itself is concerned. So these patients, definitely you cannot wait for the graft to dislocate totally. So it's better to rebubble. I've rebubbled a patient 3 times. Because of the same problem, because of the graft host. It was the very early stage, about 10 years back. I was wondering what was going on. Why is this happening 3 times? And finally, after giving a complete airful, waiting for 1 hour, the graft stuck. But these are the indications. If it's a very small separation, really you can wait.
Anyone else? Dr. Rao, sir?
I would agree, I think, because if I have my edges attached, then I will watch closely for the center, give it a day or 2. The problem with leaving the center separated for too long is that you can get a significant interface haze, which takes a very long time to go away, because there may be some admixture of sometimes a little visco there as well in spite of washing. The peripheral ones, I'm a little wary. If it's a very small peripheral one, like Dr. Sujata mentioned, I'm happy to watch. But if it's a larger one, I worry that that's the source through which the fluid's coming in. So then I may go in and tamponade it faster. But again, because it's in the AC, the endothelium is being nourished. So I don't think there's any desperate urgency to go in and do it as soon as you see it. You can use these guidelines and see if wait and watch for a day or 2, nothing wrong will happen. Because anyway, it's immersed in the endothelium. The endothelium is immersed in the aqueous. So it's getting its nourishment. So you can't, unless it's already on the iris and rubbing and all that, total dislocation, then you have to go in immediately. Otherwise, I think you can use these guidelines and give it a little time.
Just a query for people, for Dr. Revati, Dr. SKR, Dr. Sujata, and Dr. Seema, I'm sure who have fellows. I was curious on how a person who's confident with PK, how many grafts of DSEC or DMEC do you think they require to be confident in the surgery? For a reasonably good cataract surgeon knows how to do a good PK.
So some of my fellows who went out, even because they finished quite a long time back, and they have not done even a single DSEC here in while doing the fellowship. But after going out, after watching many videos and other things, and even they are having their private practice, and they send the pictures my first DSEC, my first DMEC, like that. It's just, you just jump into it. And of course, I used to advise them, practice with your, if you can get training corneas, practice as much as possible for get the hang of it. But otherwise, because after seeing so many videos and attending many meetings, I think many of them are confident enough to go ahead and do.
Revati, I'm one of those people. I think maybe I'm the oldest amongst this group. I've not had a cornea fellowship training at all. So I started doing it after watching videos, just like how we started doing phaco's. So now, fortunately, there are so many YouTube videos and it's so easy to learn. You really don't have to, I think it's more of the clinics that you have to learn than the surgical techniques, because there are so many videos. I don't think that should be a problem at all. As long as
that I think it holds good for all of us, even Dr. Rao and myself. During our fellowship, we have not learned even DALK. Of course, later only by watching and by reading it out and doing it. So
on that note, sir, for a pediatric congenital hereditary endothelial dystrophy, like for pediatric cases, would you prefer doing an endothelial keratoplasty only always, or do you do a PK also sometimes?
Yeah, it depends on the thickness. If it is too thick and too cloudy cornea, then I prefer a PK. Otherwise, of course, you can give it a try. If you can intervene before it becomes too cloudy and too thick, the cornea, then I have done both in some cases.
Do they respond, Dr. Revati? Because I especially in the CHED, which some of them present early, some of them tend to present in the early teens. In doing a DSEC or a DMEC, do they actually clear over a period of time? How's your experience been for EK and CHED? Because
yeah, they clear. They clear. And even surprisingly, Dr. M. Srinivasan always used to tell, not that we have to intervene very early in these patients, because though they have this cloudy cornea, many of them, they have reasonably good vision and they will perform in school also. They will be studying in regular schools. So only when they started getting microcystic edema, and that stage only will be intervening. And if the stroma is not too thick and not too cloudy, you can go ahead with even DSEC. I have not done DMEC, of course. I have done DSEC, and they cleared. And even PK, of course, it will be definitely, it will clear.
The other thing is, in these patients, what you have to watch out for is glaucoma. That is, it's very difficult to measure the pressure in these patients.
Yes.
And you have a very clear graft and the patient's eye is lost because of glaucoma. So that's very sad. That is one thing I think we have to, that is more important than whether you're doing a DSEC or a PK. That once you touch the eye, the chances of glaucoma is very high.
Also,
Revati ma'am, just a question regarding CHED cases with DSEC, if you're doing, or anybody seniors on the panel, open to all, how easy or difficult is the Descemet's scoring? Because I have done only in one case so far, and I found that the Descemet scoring in a CHED case was extremely difficult. So what would your take be on that?
Yeah, it will be like a failed graft or something. Sometimes it's not so easy to peel off the endothelium, the Descemet's. And I think I remember in one case, I just left it and I went ahead with DSEC.
Yeah, so that was more like an NDSEC. What I ended up doing was more like an
that particular case. Sometimes because that endothelium is not functioning, it is not normal.
Correct.
That is why. Dr.
Any
Rao,
experience of the panelists for NDSEC, NS non-stripping for Fuchs?
I personally have not done DSEC in CHED. The last one I did was PK. And like the madam mentioned, like Dr. Srinivasan in all his wisdom, this boy kept postponing surgery till he was 8 years old. So I did him about 8 years ago, I think both eyes. So he's now fine. He's about 6'12" in one eye and 6'9" in the other. So amblyopia, not so much. And if it's a proven CHED, even in a PK, we've done a fair number when I was at SN and all that. Glaucoma was not much of an issue. Unlike, like Dr. Sujat was saying, if you have any of the other anomalies like Peters and things like that, then glaucoma is 100% there. So you do the graft is clear, glaucoma will worsen. They do the glaucoma, the graft will fail. So you keep going back and forth. But CHED, at least my experience, not so much. I haven't done a lamella posterior replacement. I haven't seen a child in the last 4 years with CHED. So after I got comfortable with DSEC, so I've not had to decide. But I suspect
any feedback regarding non-stripping Descemet's endothelial? I mean, non-stripping Descemet's.
Only in
for Fuchs, does it work? Because I'm still very skeptical. I mean,
Anand, I did for one case with non-stripping. But the unfortunate thing is the patient has those interface opacities, those gritty looking things in the interface. So that actually hinders the vision, that still the scattering of light is there. So the other eye, I stripped the Descemet's. So I just attended one of the courses from Price. So I thought, why not try on this patient? Then I realized that's not the right patient to try. But you can do on pseudophakic eyes, you can do on post-phakic corneas.
Yes.
You can do.
The main indication is TAS. I find it very hard to strip it.
Yes.
So in TAS, I will not even make an attempt. If I've decided not to do a PK, but attempt a lamella, I will just go in and vacuum the endothelium off with my Simcoe. And then I don't even make an effort, because most often you get into the Dubas layer and then you'll end up with a very irregular posterior one. But the other one, including a graft, it's okay to do it, provided you just strip within the scars caused by your suturing in a PK. So it's only if you go beyond it, between those scars where you penetrated and the graftose junction, that you'll get caught. If you stay well within the suture line, even in a PK, it will come off quite easily.
Any experience with the use of ripasudil as for early treatment of bullous keratopathy? What is your experience?
It's useless.
Useless. Any? Just curious, because
and if you use it in somebody with,
I think SEMA tried cases. SEMA, I think you tried.
Ma'am, there were a few cases which have been done here, more of the Descemet stripping only, the DVEC or DSO, which is called, and with followed by ripasudil. It's like an ongoing study thing which is happening. Again, we've found cases which have worked, as well as cases which have gone in for a DSEC or DMEC after say 6 months or so. So we get to analyze the results to see which are the kind of cases that are working or not. But yes, I think it's more of the DSO rather than the ripasudil. I don't know how much which.
What about a DVEC?
But for a PVK, I think it's just not ripasudil would.
And usually we take it as an additional medicine after the first line of therapy. So it's actually questionable.
If you use it when there is already significant edema, you'll make them worse. You'll get the honeycomb.
Yes. Reticular edema you will get.
Because the isoform of rock that is used for endothelium in all these studies by Kinoshita and George in Singapore is the other version. It's the Y form.
Yes.
So it's not commercially available. So this is used even in Japan. It works on the trabecular meshwork endothelium and helps in glaucoma. Theoretically, we keep adding it here, but in my experience, it's been absolutely useless, and it stings a lot. It hurts the patient. Pointless.
Allergy. Many of them will develop allergy also.
And the first thing I do
question was about DVEC.
Who's on
DVEC. Any feedback on DVEC?
That's the one we're talking about.
That's what.
Yeah,
DVEC or DSO.
Without the ripasudil, only DVEC alone.
Yeah, that's what you have to try. Like as Seema said, just DSO also may work, because the endothelial slides even may slide and cover a small. I mean, if it is a limited area, like during our cataract surgery, sometimes we may damage a small area of Descemet strip. Can occur, and later it will recover like that.
Right.
So whether really these ROCK inhibitors are the ones what we have in the market, whether they are really helping, we don't know.
And the first thing I do when I see a patient on ripasudil, and if I'm planning an endothelial keratoplasty, is I would stop the ripasudil the first thing.
Yeah.
Because ROCK inhibitors are supposed to mobilize the peripheral endothelial cells to migrate more towards the center and cause the edema to clear. So here I want a good reserve in the peripheral endothelium when I'm planning for an EK to begin with. So I would definitely stop ripasudil when I'm planning an EK.
Can you highlight the indications for a DSO, Dr. Seema?
It's not that we are doing DSO on a regular basis. It's just that there are these cases where have been tried, but coming to indications, I would say that it would work well if at all for those cases which are going in for a combined cataract surgery, and you know that there is fuchs endothelial dystrophy, but not to the extent that the stroma is already edematous. So I would say a grade 2, early grade 2 kind of fuchs would be probably the cases where you have severe significant guttae but not stromal edema yet. Probably those kind of cases, grade 1, grade 2 kind of cases where DSO would work. Once the edema is already set in, the way to go would be a combined endothelial keratoplasty along with a cataract surgery.
Yeah. So it's almost
The
near.
concern is that in some of these patients where the DSO doesn't work, they end up with some scarring, which can interfere with the subsequent procedure as well. So that's
Yes, it
because it's a
does.
hit or a miss. It works sometimes and it doesn't work. And in the ones where it doesn't work and it crosses that little haze there, then it's in the center. So then later on, even if you do a great DSEC, it's hard to do a DMEC in that situation anyway. So in good DSEC, you will have a visual compromise. So I think the literature is not very clear. There have been some small case series where they claim it's worked, and there are equal number of case series where they show it doesn't work. So I would say it's plus minus.
Oh, shall we call it a wrap, sir?
Yes.
In a time.
Nirmal, sir?
Yeah. Thank you, everyone. Thank you, Sharmila. And thank you for sharing your valuable. So I never sat through 2 hours of cornea webinar, sitting for a long time. And it was really amazing to see the progress. But when we started, I think it was only keratoplasty and non-stop suturing, 1632 suturing. But now over a period of time, I was looking at the timeline and few of the old TNOA journals, which started keratoplasty in monkeys. There was one article in 88 or so. And see the progress that has happened in 30 years. That's really amazing. And with such eminent speakers and panelists, it was a real academic delight. So thank you all so much for sharing your wonderful time and expertise with TNOA members. I hope this will be a very useful resource for the postgraduates as well as the corneal surgeons who are going to start their practice, as well as experts also. So thank you so much, and I hope the viewers and our members would be benefited by this resource. So this will be available in our website. So if you are not logged into the full program, you can always go back and log into our TNOA website and see the entire proceedings. So thank you all so much. And so I think it's too late for dinner time also.
Thanks to the President, Nirmal, sir, for this amazing initiative. We always have a gap between the supply and the demand, and there are a lot of activities happening, and this webinar was initiated by him. And thanks to Vice President Sujata ma'am and Secretary Sriram sir and all the TNOA members.
It's by the entire team TNOA. So thank you all for your support and cooperation. So good night.
Thank you. Good night.
Thank you. Good night.
Bye.
Thank you.
Thank you, Manjula and Numerotech.
You can wrap it up, Manjula.
Thank you, Dr.